Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Shrujal Baxi. She's an oncologist, and today's Kevin MD article is titled Removing Workflow Burdens and Improving Access for Colorectal Cancer Screenings. Shrujal, welcome to the show.
Thanks, Kevin. I'm happy to be here.
So we'll talk about your article in a bit. Let's start by sharing your story and journey to where you are today.
Sure. So as you stated, I'm an oncologist by training, but I really started out very interested in public health and healthcare delivery and how we were going to improve patient outcomes by changing the way we actually deliver care. And so my research when I was in academics was really focused on using data and technology to solve those types of problems. I transitioned out of academics about 6 years ago now and have spent time in industry really trying to find the space for technology to do just that, which is either make it easier for doctors to be doctors so that they can do what they want to do, which is take care of the patients, or find ways to bring solutions directly to the patient so that they're getting better outcomes. And so now I work at this company called Iterative Health as the chief medical officer. And at Iterative Health, we're trying to see how computer vision can actually improve insights and efficiencies from endoscopies, which are predominantly performed by gastroenterologists.
Perfect. So tell me about your journey into industry from academics. I talk to a lot of physicians who make that transition for a number of reasons, but tell me about your particular journey.
It's a really good question and almost a serendipitous opportunity that was presented late 2017 in oncology. We were really at the precipice of sort of the game changer, which is immunotherapy. And I was trying really hard to develop large databases within the context of an academic center that could do the kind of real-time insight generation that I thought the space needed. And it turned out while I had sort of the fundamentals from a clinical perspective and what the data needed to look like, really to, ingest it, process it, make it ready for research, required a team of people that I couldn't get access to in academics at the time. And I happened to be partnering as a consultant with a company called Flatiron Health that had done just that. They had figured out how to do tech-enabled large database development using EHR data. And I actually joined Flatiron in 2018 thinking it was going to be a 2-year internship to really understand the nuts and bolts of what it was, and got there and was just turned on by the speed and the pace and the cross-functional nature of what was happening. And so in a really practical sense, it just sort of stumbled upon the journey from academics to industry. But when I look back and I reflect on the kinds of grants I was writing to develop technology and implement at the point of care, what was really interesting is there's a lot of great ideas. But to take those ideas and actually commercialize them or make them available to the population requires a set of skills that in most academic centers were neither taught nor supported to do. So to do research to write a paper is very different than to do research to actually change care. And that was really what tech and the industry sort of allowed me to do, which was actually fulfill what I was trying to do in the first place.
So how did you get that training to go into industry? Was it on the job? Did you have any courses like in terms of that transition?
I think by background, I've always been a data scientist before that had a name, because I was always thinking about what does data look like? And that was sort of my first foray into tech. It was an easy transition because I was already doing outcomes-based research as an academic clinician, and now I was doing outcomes-based research in an industry environment. And so what that transition from my academic hat to the industry hat allowed me to do was to still be a subject matter expert in oncology, which was natural, and to work in the part of health technology that I was most comfortable, which was large database research. What I learned, though, was all the other stuff. How do you have cross-functional teams? What does product market fit look like? How do you generate research that is relevant for the drug development life cycle as opposed to at the very end? So it was sort of like understanding the business side of it as opposed to sort of the academic side where you get to ask the question that's most meaningful to you. I learned how you ask questions because asking the question is fun in and of itself,
Sure.
and figuring out how to do that quickly and effectively. And so I don't have an MBA, I don't have a business background, but I have had a crash course in understanding from funding to financing to scaling to selling to building to, all of those things are all just on the job learnings that I've sort of grown over time.
So let's talk about your Kevin MD article. We talk about colorectal cancer screenings. Your article's titled "Removing Workflow Burdens and Improving Access for Colorectal
Yeah.
Cancer Screening." So tell us, how did this article come together?
I mean, I think the article started as really a question of, given where we are as a company trying to advance technology and AI in endoscopy, sort of seeing barriers put up for clinicians to actually be able to provide endoscopies to their patients sort of felt like it hit really close to home, because we want to make it better, easier, faster, broaden access. And that decision, while I really appreciate what they were trying to accomplish, felt like trying to solve a problem with a sledgehammer. And we were trying to sort of highlight that in that conversation. But in the context of writing that paper, you sort of have to take a step back, and what is our role as an AI company in the endoscopy or care delivery space? And it sort of allowed me to reflect a bit. And what I realized as I was writing it is that as a tech ecosystem in healthcare, we do need to do a better job of highlighting what we're solving for.
Mm-hmm.
And where is the value of what we're doing going to be generated? Sometimes the value is it's just the right thing for the patients. And if it costs a little bit more, it's worth it because the patients are going to benefit and it's a long-term return on investment. And when you talk about colonoscopies as a screening or diagnostic tool, oftentimes that is where the return on investment might be. But then we thought about what are things that we're also developing that help the provider with efficiency in care or effectiveness in the care they're delivering, such that it's one less thing for them to worry about. And it actually turned out that what we're building, polyp detection software, actually hopefully helps them feel a little bit less stressed when they're doing their procedures, so that it's like just one less thing for them to be worrying about
Sure.
in this environment, and so it's a long answer to your question, but it started out from just a gut reaction to what was happening in the payer space, to a bigger reflection on what is our role in gastroenterology and
Sure.
endoscopy.
So for those who didn't get a chance to read your article, just give us the context of what the issue was and how your solution approached that.
Yeah, I mean, I'll start by saying that our solution doesn't actually solve the problem. It's part of the broader conversation, right? Which is you want to make sure that the right patients are getting the right procedures to enable access for the right people at the right time, to save the system money, because we know as a country, we spend a lot of money on healthcare. And the article talks about a decision that was made at the time by United Healthcare to consider having pre-authorization for diagnostic colonoscopies. And, we work very closely with the GI community, and they were all very concerned that this type of administrative burden only added to what is already a series of choices that are being made in the space that are leading to burnout, right? And we were sort of putting forward this idea that the idea might be right, but the application across the board writ large was probably overkill. And how do we get to a place where payers and providers can align on policies that are both benefiting the payer by containing costs, but also benefiting providers by not increasing their administrative burden, which is already quite intense and leading to, record levels of burnout, which we talk about all the time.
So these are diagnostic colonoscopies. Like, can you contrast that from a screening colonoscopy?
Yeah. So a screening colonoscopy is anything screening implies that you are doing a routine evaluation to evaluate for something. So a screening colonoscopy is done to evaluate, sort of an average risk person for, early detection of colon cancer. That's a screening colonoscopy. Most people will need a screening colonoscopy once every 10 years. The recommendations say start at 45. But if you are found to have something, you have a reason to get a colonoscopy, there's some symptom.
Yeah.
Now it's diagnostic. There is a purpose to it. You are looking for something specific.
Sure. So, for instance, if someone had a fecal blood test that was positive and a subsequent colonoscopy was offered, that's now considered a diagnostic colonoscopy, correct?
That's exactly right. Because now you're evaluating an abnormality.
So, with this health payer potentially adding an obstacle to order that, like prior authorization, how does that affect both the physician and the patient?
So, it's a good question. And I'm sure there's people that are studying the impact of policies like this. I do think that for physicians, part of it is just yet another thing,
Yeah.
right? I happened to train
Mm.
when we went from paper to EHR. And that was probably the single biggest leap in care delivery
Mhm.
in my, career. But it was catastrophic in terms of the disruption it caused in workflow. And so I think of every next thing that might seem small to an outsider looking in, like, why are they complaining? They just got to fill out some forms. But if you can imagine, everything has that next burden. It's leading to sort of this feeling
Mhm.
amongst practitioners that, is it really worth it? It's so hard. Why should being a good doctor be so hard? And I feel like that part of it for physicians can't be underestimated, because the number of physicians that are leaving practice because they just aren't sure they want to keep doing that stuff. You rarely hear it's because of the care
Yeah.
or the patient. It's this stuff that is burning people out, right? And so do I think it would have broke it? I don't know, right? But there might be a physician out there who's like, that's it.
Yeah.
I can't anymore. But those things are coming rapidly and they're just tired. It also costs practices, right? Many GIs are still private practices, or even large academic centers or large community-based practices. You have to pay somebody to do those administrative tasks. So now you've added another layer of that overhead,
Sure.
which that is an expensive part of our healthcare system, is how much we have to pay to just get paid, right? And I think that that's also very disheartening for physicians. And then from a patient's perspective, you have a symptom and you're like, my doctor's telling me I need to get this done. And now I'm going to wait because the insurance company denied it. Like, I
Mhm.
emotionally, as someone who's getting a little bit older and I think about my health, I take for granted that when I need something, it's there and available. But it's clear that these hurdles are just making it a little bit harder. And for the wrong patient, might actually dissuade them from seeking care. And that all matters, right?
So you're in the tech space and you mentioned AI. What are some innovative approaches to alleviate that administrative burden that you're seeing in that space?
Right. So this is actually, I thought, once we wrote that article with you, the interesting part is like how we think about AI and its role to play in medicine, right? And so the one that I think is really sexy that everyone likes to talk about is sort of, we're going to see things that a human can't see: pathology, radiology, endoscopy. We're going to pick up patterns faster or more standardized. And that's a lot of what computer vision does, is direct passage of information that the AI can generate to the physician to either give them confidence in what they're doing or provide insights that a tired radiologist or a tired gastroenterologist at the end of the day might not pick up, that they would have picked up at the first read of the day, right? Like,
Hmm.
all of that is really sexy. It's really hard though, right? Because that work requires an incredible amount of validation, because you are now putting that AI as part of the physician sort of psyche and delivery of insights, its knowledge, its care, right?
So
But
as
there
it
is
relates
another,
to
yeah,
colorectal cancer screening, like how exactly
yeah.
would that work?
Oh, okay. So that's a great question. When a for those who've never had a colonoscopy, when a physician does a colonoscopy, you're in this room, they have a camera at the end of a long tube, the endoscope, and the camera, as it's inserted into the colon, projects a vision onto a screen, almost like you're playing like a video game. And the physician is going to advance the colon, the endoscope, all the way to the end of the colon and take a look around and look for abnormalities, polyps, maybe some areas that look colored differently, things like that. And what they're going to do is they're going to look along the way, look for the abnormalities, and the things that look suspicious, they're actually going to biopsy and take out so that you have pathologic confirmation of what they saw.
Sure.
The way that AI works in this space is that it's running right along with the physician. So as you're looking at the computer screen, AI is going to generate a square onto the screen that's like, hey, I think there's a polyp here. Hey, I think there's a polyp here. There's a polyp here. And the physician can say, you know what? Thanks, AI. I don't think so. And make their choice. It's not making the decision. It's aiding the physician to make sure they don't miss something. Or maybe it picks up something the physician's like, I need to look a little closer here. I didn't see that, right? And the idea, it's just computer assisted sort of detection. It's not diagnosing anything. And the goal of it is really to make sure when you and I do our once a 10-year colonoscopy, we get the full look.
Yeah.
So that we feel confident as patients that, hey, someone looked at all the things that might be abnormal. And there are clinicians out there that are very good at this, and their benefit from the AI might be a little less than someone who's new and just coming out or really tired because they've had the flu for 3 weeks. Like you could just see how this kind of technology will level up everybody to a standard.
Sure.
So that's how our technology works. And so it's sort of not fully diagnostic, but it's helping the physician feel more confident and be better, and the patient feel like they had a good quality, everything was looked at, regardless of whether you got the best gastroenterologist in the world or someone who's, middle of the pack.
Now, where are we in terms of the development cycle and in terms of outcomes data for AI-assisted technology like this?
So I think that that's a really good question. I think one of the things that we focused a lot on is making sure we don't create a lot of noise. We don't want to create sort of that alarm fatigue phenomenon with this tool that we've seen with other sort of helpful, technology. And we are double downing on making sure that we're not only sensitive, but that we're specific enough in our presentation of what we think is a polyp or an abnormality, such that the physicians don't sort of ignore us.
Sure.
Outcomes data takes a little bit of time, right? So we have sort of surrogates. Surrogate would be like a true histology, right? Making sure that the things that we're pulling out are actually pre-malignant or adenomas, and they're not the hyperplastic, never going to become malignant things. Physicians in general are going to pull out everything they see. So it's not that it's 100%. If physicians knew what was bad and not bad, they would never cut out everything. So we want to make sure that we are not increasing the burden on physicians for biopsies and things like that. So we are measuring currently the true histology rate of the work we did by different factors to really give insights to clinicians about this is actually a good thing. It doesn't increase the duration of your colonoscopy. It doesn't increase unnecessary work for you. And so we're sort of building some of that out. But the true outcomes data that matters is really, does doing AI-assisted colonoscopies decrease the rates of colon cancer? And so we are lucky because we ran the largest randomized clinical trial in the US at the time to actually get our polyp detection tool to market. And we're now going back, and we're actually going back to see, can we collect outcomes data? Because you need time for screening data to mature. And, I'm sure you've spoken to plenty of people about the constant sort of debate in the public health space about what is the right frequency, what is the true benefit. And we're currently working on collecting some of that outcomes data to actually do the true follow-up from our randomized controlled trial, because sometimes it's hard given a lot of the other factors, socioeconomic, family risk factors, to really get a clean answer. And it may be that we're not mature enough yet, because it takes years to see the benefit of screening protocols.
So you mentioned that the ultimate goal, of course, is to maximize that sensitivity and specificity. So where are you? How close are you to your goal?
We're actually already on the market with a commercialized device that's getting good reviews from the physicians who've had the opportunity to use it. And so
Yeah.
we think it's good, and we're getting a really good signal. But because we're an AI company, we always want to be better.
Okay.
And so we continue to iterate on what are the things that we can do to make our device help physicians better. And we're taking feedback from clinicians. We all just came back from the American College of Gastroenterology, annual meeting in Vancouver, and we heard clearly what physicians are looking for. And they're telling us that there are certain kinds of polyps that are really challenging to them. And is there something our AI can do to help? And so that's the kind of feedback that we look to continually evaluate, build models against, and then push out, because we imagine that this is an iterative process, no pun intended.
We're talking to Shrujal Baxi. She's an oncologist. Today's Kevin MD article is titled Removing Workflow Burdens and Improving Access for Colorectal Cancer Screenings. Shrujal, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
So I guess I would have some take-home messages directly to the different stakeholders in this space, right? So one, I would say to physicians who listen to your podcast, I think technology can help us. It can help us deliver better care. It can give us confidence in the care we're delivering, but it is good to be skeptical and ask questions, and to push companies like mine and others to do better, always. We are all in it to give better care. And so I think that one of the challenges being a physician in this space is threading the needle between what we can do, what we should do, and when can we do it. So it's not that we're not going to solve all the problems eventually, but what is the natural sequencing of order such that as we're putting out iterations of products, we're actually solving pain points in the day-to-day workflow of physicians. And so to those who speak to people like me, keep the ideas and the pain points flowing, because that's how we know what to build. To patients, I was going to say that I think that AI is the next level of care that can help guide and give you confidence in the care that you're getting. And so while there is sort of a distrust sometimes that's built into the system, I think that AI that helps physicians be better physicians is exactly where I want to see it positioned. As an oncologist, I don't want anybody but a human talking to me about my conditions. But if AI can help my physician understand the data faster, then I want AI to be part of the conversation.
Shrujal, thank you so much for sharing your time and insight. Thanks again for coming on the show.
Kevin, this was great.